Chemoprevention of breast and prostate cancer with tamoxifen and finasteride. Breast cancer accounts for 15% of all female malignancies worldwide, while prostate cancer represents 25% of male cancers in the United States. Tamoxifen, a selective estrogen receptor modulator, and finasteride, a 5-alpha reductase inhibitor, reduce the incidence of these cancers by targeting estrogen-driven proliferation and dihydrotestosterone-mediated growth, respectively. Risk stratification using the Gail model, greater than or equal to 1.66% 5-year risk, for women, and the Prostate Cancer Prevention Trial, PCPT, risk calculator, greater than or equal to 25% 5-year risk, for men, identifies candidates for chemoprevention. Primary management involves daily tamoxifen 20 mg or finasteride 5 mg for 5 to 7 years, with baseline and periodic monitoring of liver enzymes, endometrial thickness, PSA, and sexual function. Key points. Note: tamoxifen 20 mg orally daily for 5 years reduces invasive breast cancer incidence by 38%, RR 0.62, in high-risk women, SAB-P1 trial. Finasteride 5 mg orally daily for 7 years reduces prostate cancer incidence by 25%, RR 0.75, in men with baseline PSA less than or equal to 3 nanograms per milliliter, PCPT trial. Number needed to treat NNT. To prevent one breast cancer is 50. Number needed to harm NNH for endometrial cancer is 250. NNT to prevent one prostate cancer is 27. NNH for high-grade, Gleason greater than or equal to 7. Prostate cancer is 125. Tamoxifen increases venous thromboembolism, VTE, risk from 0.5% to 1.5%, absolute increase 1%. Finasteride raises the incidence of sexual dysfunction from 1.3% to 2.1%, absolute increase 0.8%. Baseline liver transaminases, ALT 7 to 56U/L, AST 10 to 40U/L, must be less than or equal to 2 times upper limit of normal before initiating either agent. Postmenopausal endometrial thickness greater than 4 mm on transvaginal ultrasound warrants diagnostic hysteroscopy, sensitivity 85%. PSA values on finasteride should be multiplied by 2.3 to account for drug-induced suppression. A corrected PSA greater than 4 nanograms per milliliter triggers biopsy. CYP2D6 poor metabolizers have 30% lower endoxifen levels, reducing tamoxifen efficacy. Genotype-guided dosing, 30 mg daily, may be considered. Overview and epidemiology. Chemoprevention refers to the use of pharmacologic agents to halt or reverse carcinogenesis in at-risk individuals. Breast cancer, ICD-10C50, accounts for an estimated 2.3 million new cases and 685,000 deaths globally in 2022. H standardized incidence 46.3/100,000. Prostate cancer, ICD-10C61, contributed 1.4 million new cases and 375,000 deaths worldwide in the same year, incidence 30.0/100,000. In the United States, breast cancer incidence peaks at age 62, rate 129/100,000, and is 1.5-fold higher in non-Hispanic white women than in black women, whereas prostate cancer incidence peaks at age 70, rate 112/100,000, and is 1.6-fold higher in African American men. Economic analyses estimate the annual direct cost of breast cancer care at US $20.5 billion and prostate cancer at US $12.5 billion, 2021 data. Modifiable risk factors for breast cancer include alcohol intake greater than 15 g/day, RR 1.30, obesity, BMI greater than or equal to 30 kg per square meter, RR 1.25, and hormone replacement therapy, RR 1.35. Non-modifiable factors include BRCA1/2 mutations, RR 5 to 10, first-degree relative with breast cancer, RR 2.0, and early menarche, less than 12Y, RR 1.20. Prostate cancer risk is elevated by African ancestry, RR 1.6, family history, RR 2.5, high-fat diet, greater than 30% kcal from fat, RR 1.20, and sedentary lifestyle, RR 1.15. Pathophysiology. Tamoxifen is a triphenylethylene selective estrogen receptor modulator, SERM, that competitively binds estrogen receptor alpha, R, and beta, R, with an affinity of 0.5 nanomolar, blocking estrogen-driven transcription in breast epithelium while exerting partial agonism in bone and endometrium. Metabolism occurs primarily via hepatic CYP2D6 to generate 4-hydroxytamoxifen and endoxifen, the latter possessing a 30-fold higher antiestrogenic potency. AC5 is almost equal to 0.1 nanomolar. In preclinical MMTV-PYMT mouse models, tamoxifen reduces tumor latency from 12 weeks to 20 weeks, p less than 0.001, and downregulates cyclin D1, BCL2, and VEGF expression. Finasteride inhibits type 2,5-alpha reductase, decreasing conversion of testosterone to dihydrotestosterone, DHT, by greater than 90%. Serum DHT is almost equal to 0.5 nanograms per milliliter versus 10 nanograms per milliliter baseline. DHT is the principal androgen driving prostatic epithelial proliferation via androgen receptor, AR, activation. Reduced DHT attenuates AR-mediated transcription of PSA, TMPRSS2-ERG, and Ki67. In the tramp mouse model, finasteride lowers prostatic intraepithelial neoplasia, PIN, incidence from 78% to 42%, p less than 0.01, and delays carcinoma onset by almost equals 6 months. Clinical presentation. Because chemoprevention targets asymptomatic individuals, the clinical presentation pertains to risk assessment findings rather than disease symptoms. In the ZAP-P1 trial, 85% of eligible women were identified by a 5-year Gail risk greater than or equal to 1.66%, 12% presented with atypical ductal hyperplasia on prior biopsy, and 3% had a prior lobular carcinoma in situ, LCIS. For prostate cancer, the PCPT enrolled men with PSA less than or equal to 3 nanograms per milliliter and a negative digital rectal exam, DRE. 7% had prior high-grade prostatic intraepithelial neoplasia, HGPIN. Physical examination in high-risk women is often unremarkable. However, breast density categorized as BIRADS4, heterogeneously dense, has a sensitivity of 78% for detecting occult malignancy. In men, DRE sensitivity for detecting clinically significant cancer is 52% with specificity 94%. Red flag findings requiring immediate evaluation include a new breast lump, PPV is almost equal to 30%, unexplained nipple discharge, PPV is almost equal to 22%, or a rapidly rising PSA, greater than 0.75 nanograms per milliliter per year, PPV is almost equal to 45%. Diagnosis. A stepwise diagnostic algorithm for chemoprevention begins with risk stratification. 1. Risk assessment key points. Women, Gail model greater than or equal to 1.66% 5-year risk or presence of LCIS/ADH. Men, PCPT risk calculator greater than or equal to 25% 5-year risk, PSA less than or equal to 3 nanograms per milliliter, DRE negative. Complete blood count, CBC hemoglobin 12 to 16 g/dl, women, 13 to 17 g/dl, men. Liver function tests, LFTs alt 7 to 56 u/l, AST 10 to 40 u/l, both must be less than or equal to 2 times ULN. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.